Hello, everyone. My name is Kyle Kravetz. I'm one of the cardiac anesthesia fellows at Texas Heart Institute, and today I have the privilege of giving a grand rounds presentation specifically on echocardiography from a case that we have. There's a lot to go over. It's about a 30 to 40 minute talk, so let's get started. First thing is, I don't have any financial disclosures. We're going to go over 5 objectives. We're going to review a cardiac case that we had over at the Texas Heart Institute, and then talk about a concept called LVOT obstruction, specifically systolic motion anteriorly of the mitral valve. We will address hemodynamic stability, instability, and how we use rescue echo to potentially fix the problem or find ways to temporize the patient. We'll also go over some rescue echoes. I want to first acknowledge Dr. Josh Zimmerman. He was a mentor of mine in residency at the University of Utah. They have excellent free content. He has dedicated his professional life and personal life to bettering echocardiographers all around the country. He also offers free questions of the day. If you sign up, there are people from over 50 countries that subscribe to his content. It's fascinating. And so I want to first say thank you to him, as some of these slides are from him directly. The first concept I want to talk about is something that is misunderstood in our specialty. Anesthesiologists in general are misunderstood by and large because we find solutions to complex problems. And what I want to focus you on is, particularly in the middle, you could substitute anesthesiologist, but anyone that is in any one of these roles could potentially interact with an anesthesiologist in some capacity. Cardiac anesthesiologists in particular have the fortunate privilege of understanding not only being an echocardiographer, which is in combination of being a sonographer, an interpreter of the echo, in addition to performing the echo, in addition to all of the interventions associated with hemodynamic stability, in addition to communication with all of our proceduralists, interventionalists, and or surgeons. And so rescue echo combines all of these different modalities into one to potentially save a patient's life, which in my opinion is the real reason why I particularly pursued anesthesia, as I do feel that we can save lives. The first component in this I want to discuss is that this, whether you pursue cardiac anesthesia as a formal training, the TEE, I just took the oral boards, and it is a very dynamic process, and it was not at a 101 level. The TEs that they had were, I would say, intermediate or advanced in nature, and so it is worth spending some time studying this. I have this picture hanging in my office, and the reason I have it in my office is I think that this is somewhat of how anesthesiology, particularly cardiac anesthesia, is viewed in my eyes. You have a guy who's in the trenches. He's clearly hasn't bathed or showered, and he is trying to find solutions to problems that have otherwise wiped out not only his comrades, but this is kind of what it can feel like in an emergency situation where you're performing rescue echo, where you're taking shots down range, so to speak. And so I find studying this helpful because it gives you confidence in the midst of what we call battle. If you don't remember anything from today, I want you to remember a concept when you get into these high stress situations of where's the blood. If you run into a situation where you're unsure of what's going on, it's very easy to say, where's the blood and how do we get it to the right place? I'm going to first talk about a cardiac case we had with Dr. Hallman. We had a 70-year-old female who presented to the Texas Heart Institute. She did not have any out-of-control systemic comorbidities, but she presented to our particular quaternary care hospital for severe low flow, low gradient aortic stenosis, coronary artery disease, and likely WHO class 2 pulmonary hypertension with preserved RV and LV function. And she presented for surgical revascularization and aortic valve replacement. All things, for the sake of the presentation, went in their standard fashion, except when we weaned from cardiopulmonary bypass, we encountered something that would look similar to this. So a little bit after 2 o'clock, we developed some ST changes, specifically likely an air embolus down the right coronary artery, as this is anteriorly placed, which happens especially when we do open heart surgery and we actually open the heart itself for a valve replacement. We developed left ventricular akinesis of the wall. We also developed some RV dysfunction. There's 2 options in this scenario. You can either go back on the cardiopulmonary bypass, rest the heart, press the diastolic dysfunction up, or you perform what I call informally a full court diastolic press, where you try to push the air through the coronaries in order to push that air pocket through to regain appropriate perfusion. So what did we do? We ended up going on and off bypass a couple times, and because of this RV or this shot of air, we put the patient on some inotropic support. We managed the hemodynamics, and then because the patient was hypertensive and tachycardic, after we had proceeded off bypass, we developed sinus tachycardia, hypertension, and so what do? We lower the blood pressure. Well, when we lowered the blood pressure, the patient very quickly arrested. It didn't look quite like this, but I just want to put you in some form of, to try to imagine what you're seeing on the vital signs to recapture what was happening. So unfortunately, we had to perform cardiac massage, reheparinization, crashed onto bypass after placing an additional arterial cannula into the ascending aorta. And what we encountered was this.
The
patient had to be placed on peripheral VA ECMO for hemodynamic instability. And so what I want to show you is how this would look like, assuming we had better images. So this is a mid-esophageal long axis view, left ventricle, left atrium, and then ascending aorta here with the aortic valve. As you can see in a 2D color of the image, during systole, when the valve opens, this is one of the leaflets of the anterior valve, and this is called SAM. This is systolic anterior motion. This anterior motion is towards the aortic valve, and you can see this here in the next slide in color. So all of this flow here, this is all turbulent flow that's seen in the left ventricular outflow tract. So this is SAM, and this is also seen here. We have what's called a Y sign, and what happens in SAM is the blood flow, I'll talk about this in a minute, but as the blood flow enters, instead of ejecting into the LVOT, because there's an obstruction in systole and the blood can't exit, it goes back up the left atrium. So let's first talk about what is the normal process of flow. So normally the LVOT is positioned with enough room so that during systole blood can exit through it. The pulmonary veins will empty as the ventricle fills, and you have very laminar flow. We remember this from physics as far as Reynolds number and laminar flow versus turbulent flow. So under normal conditions, the ventricle fills, the ventricle ejects, there's no muscle in the way, and there's no anterior mitral valve leaflet in the way. And ideally, blood flow will flow in a clockwise direction down the posterior wall to the apex and up the anterior wall and through the LVOT. However, in SAM, there's a couple different physical principles that occur that make blood flow out of the left ventricular outflow tract not as laminar. The first is that the anterior leaflet is pulled to where it doesn't coapt in the same manner. So the posterior leaflet is pulled this way. And when you pull this leaflet towards the interventricular septum, it causes posteriorly directed mitral regurgitation. The key point is blood is not pushing forward out into the ascending aorta through the LVOT, and so it's altered. So what ends up happening is you create counterclockwise flow of blood. So instead of it going down here like this, it actually goes back in the other direction and back through the potentially causing pulmonary edema. So when I was first studying SAM, I thought, well, why is this important for the general anesthesiologist to know? And SAM is not isolated to cardiac surgery. There are certain risk factors that a patient may present with SAM, and there's a couple things. One is you could have a small elderly female patient who may intrinsically have a small ventricle that may have risk factors for it. You could potentially be in a trauma situation where you're profoundly underfilled. You could be in a liver transplant where you're massively resuscitating a patient. The other risk factors include exogenous inotropic support, tachycardia, reduced preload, and reduced afterload. This is a picture of what I was referring to with especially elderly female patients or hypertrophied hearts. Even if they don't have asymmetric hypertrophy of the heart, look at how small this cavity is. So if this cavity doesn't fill normally, as in any process where you're under resuscitated, you can start to see that this would potentially create problems. So the first thing is, how do we treat this? More importantly, how did we not treat this when the patient rearrested and had to be placed on ECMO support? The first thing is you have to volume load the patient. Blood, crystal, albumin, product, anything that allows you to increase separation between this anterior leaflet and the LVOT tract itself. Now, as you load them, keep in mind that you're still, until the SAM is relieved, going to have some component of posteriorly directed MR, so you have to watch out for pulmonary edema. You also need to have rate reduction. There's a couple things here that benefit from that. The first is you can use beta blockers to increase diastolic filling time. In addition, you want to not create as high of blood flow out of the LVOT. This is done with chronotropic or inotropic support or both, and so you want to limit the velocity of blood that's exiting the heart to allow it to fill better. The other component is increasing afterload. So afterload is the pressure in which that exerts onto the LV, and the reason why this back pressure is important is because this allows increase in wall tension, which actually allows the left ventricle to fill, and an increased pressure pushed against the left ventricular muscle, the myocardium, will decrease the velocity of blood. So it's a twofold reason why we add afterload support. What did we do in this case when we gave a little bit of nitroglycerin? The patient was already empty. We were already on inotropic support because we were protecting the RV, and we gave nitroglycerin, which bottomed out our preload. I want to now shift to rescue echo specifically. And when I was in medical school, they had this concept in cardiac arrest of the H's and T's. And I thought this was kind of silly because there's no way that most people can remember this odd algorithm that has 6 H's and 6 T's. It's been shown over study and study and study that people don't actually remember more than 3 to 4 things when the patient is not doing well or a stressful environment. Something I think is more innate and easier to recognize is these 5 equations that really sum up our entire specialty but have to be managed really well. So the first is delivery of oxygen, content of oxygen, and for hemodynamic instability in particular, we have mean arterial pressure is equal to cardiac output times SVR, We all know these equations, but I want to add it in a little bit different context for you. The first is that assuming we don't have an arterial line, which is most of the cases in the side of general anesthesia, you can see that you only have 2 out of the 5 components of hemodynamics readily available to you, the heart rate and the heart rhythm. You don't routinely have any absolute quantifiable measure of preload outside of a central venous pressure or a SWAN, and you don't have any measure of contractility, and you don't have a way to measure afterload outside of whatever the mean arterial pressure is. And so there's no way to calculate. So a lot of the times you're right and blind. However, with transesophageal or transthoracic echo, I equate it to cheating on a test. So you have all the components now to assess not only your hemodynamics, but then make interventions on that. So let's dive into differential diagnosing and how we apply this simple formula in very stressful environments. The first is you have to go into rescue echo with a differential diagnosis. You cannot just enter a scenario to say, I'm just going to put an echo down and see what I see, and hopefully I can figure out what the problem is. You need to first say, what are the patients? What do I anticipate them to be? Do I anticipate, is there bleeding right now? Is the patient volume down? Is the patient, NPO? Do I think there's a component of distributive shock? Do I think there's a component of obstructive shock? What are the risk factors for a pneumothorax? What are the risk factors for cardiac tamponade? What are the risk factors for pulmonary embolus? These are all things going into the rescue echo that will help you kind of keep your head about yourself. And this is a mental map that Dr. Zimmerman actually taught me in residency, and I really liked it because it includes several different components of shock. And so you can run through these in your head and have kind of a mental scaffolding to help keep your thoughts straight. So in our rescue exam, there's a particular sequence, and I don't want to focus on this a lot, but I think it's important to talk about it for completeness sake. The rescue exam is made to evaluate both ventricles, all 4 valves, the pericardium, and briefly the aorta and ascending and the RVOT tract itself. The University of Utah has a really fascinating study in which they evaluated several different rescue echoes, and what they found is this particular sequence was the most ergonomic and the quickest and most rapid to identify major qualitative problems that they found. So what they first do is they just get a 4-chamber heart, evaluate both the RV and the LV. This view in and of itself can tell you a lot of different information. However, a complete rescue exam is essential to not get tunnel vision. The next images they do is they perform an aortic valve both in short and long axis in the mid-esophagus. This evaluates different aortic pathology, specifically what we're talking about with LVOT obstruction. We then move to the bicaval view, specifically looking at the intraatrial septum. This is important when looking for wires and also establishing if you have interatrial communications, such as a PFO or an ASD. You then move to what's called an RV inflow-outflow with color on the pulmonic valve. You then spin around the LV using this modality on TE called an omniplane. And what it does, it just spins around the left ventricle looking at all individual walls as you just spin around. And then finally we go into the stomach to get a short axis of the LV. This is the aortic valve in a deep transgastric view, in addition to a 2-chamber view, and also the aorta, both in short and long axis, the descending. And finally, you want to look at the ascending aorta in short axis to see if you can see anything in the saddle endos. So, although I don't believe in algorithms, I believe in critical thinking. For the purpose of this talk, I think it's important to say, what is my differential diagnosis going in if I have refractory hypotension or inadequate perfusion? First, I'm going to assess what is the contractility of my LV and my RV. And then going to determine what my stroke volume is, assessing both preload and afterload. And then I'm going to assess my volume responsiveness and then make a decision as far as therapy here. This is a great slide to go back. The other component about this slide in particular is rescue echo is dynamic and requires lots of different re-intervention and re-examination of the same spots. So let's give it a shot. Let's do some practice images and see what we see. So first I want you to look at this. All of these echo images, I will have a reference here to help orient you to what is what. The goal is to not teach you all the views of echo, but rather use it as a tool to guide you. So this is a mid-esophageal short axis view, and we can see that I'll give it away that this ventricle, both on the left ventricle on the right side of your screen and the right ventricle on the left side of your screen, both look full. So in this particular view, you can see that's abnormal compared to the image that we had prior, and you can see that there is basically no blood in the left or right ventricle, especially in end systole. This patient, if you were to assess hemodynamics, preload, afterload, contractility, heart rate, and rhythm, the patient needs stroke volume, they need preload, specifically preload to the RV, which will pump to the LV. Next, I'm going to look at, specifically for Sam, the difference in the different view looking at the left ventricular outflow tract. Now, this view is established in the mid-esophagus. And so here you can see this is what it's supposed to look like. However, here we have a 68-year-old femur who presented with no past medical history and who's having her femur rotted with orthopedic surgery. And she probably, in combination to either sensible losses or blood loss, is having profound hypovolemia. You can see the left ventricle is not full, such as in the top left screen, and it's completely compressed. This patient needs fluid. The next, we're going to look at, once again, we see a hypovolemic patient. This is kind of a septal bulge here. And if we put color on this, we start to see what we saw earlier as far as the SAM. Now, if you're in this situation, I want you to ask yourself again, where's the blood, right? So if you're in this situation here, and all of a sudden you're thinking to yourself, what is going on? What is happening right now? Remember this slide about where's the blood. Sometimes it's easy. Sometimes it's on the floor. Sometimes it's in the chest. Sometimes it's in the hip. Sometimes it's in the retroperitoneum. Having an understanding of where that blood is will help you not only figure out a diagnosis, but a treatment plan. So first I want to assess, is this more of a preload issue or is this more of an afterload issue? And I would say looking at this, looks like the papillary muscles here are basically touching at the end of systole. This is more of a preload issue. In this particular case, you can see that not only are the papillary muscles touching, but it looks like it's expanding quite a bit. So this is consistent with what we call a low afterload state. A low afterload state is synonymous with, if you remember, ejection fraction, and the formula for that, it's end diastolic volume minus end systolic volume. This is a similar process. However, this is in the mid-esophagus, so we see right atrium, right ventricle, left atrium, left ventricle, and you can see that the lateral annulus of both the tricuspid valve and the mitral valve are moving, and this is what we call hyperdynamic state. Hyperdynamic states are usually associated with states such that present with a low SVR. So this is a patient that can be undergoing general anesthesia. A patient may have liver dysfunction. A patient may have sepsis. Some component is causing the heart to have an increase in cardiac output. You can see here, this is a mid-esophageal long axis view, and these images here also show hyperdynamicness, which is just the heart is trying to maximize each beat in order to keep up with its cardiac output demands. I want to shift gears to then talk about obstructive shock. Now, obstructive shock has a couple different components, and SAM, which is here DLVOTO, dynamic left ventricular outflow tract obstruction, there's multiple different reasons why you could have some component of blood being obstructed to pass through the heart. You could have tension pneumothorax, PEEP, especially PEEP that's in the high teens, cardiac tamponade, pulmonary embolus, and ACS. So you can see here, I want to first ask the audience, what's the problem, right? We see a mid-esophageal 4-chamber view. We see a right atrium that looks dilated, a right ventricle that looks dilated, and a left ventricle that looks very underfilled. You can see that there's obvious clot in transit here. This is a pulmonary embolism. You can see here, this is another mobile clot. Looks like the LV is also underfilled. The right ventricle looks like it's functioning for now, but this clot needs to be evacuated very quickly before it embolizes to the pulmonary artery and kills the patient. This is a view of the ascending aorta and short axis, where you have the ascending aorta, the SVC is up here, and then here is the right PA, the main PA, and then the right PA. This is an awesome image here where we see the ascending aorta SVC, and then we see obvious thrombus here in the main PA. You can also see this saddle embolus that's occurring here. This is an image of a case that was done at the Texas Heart Institute a couple years ago, where a patient had a true saddle embolus. So total blood flow was occluding this patient's pulmonary artery. They were in extremis, and the patient went for pulmonary embolectomy, and the patient made a recovery. This is a case, as you can see, there's not much contractility or flow. Looks very, very stagnant. This patient went into cardiac arrest from a massive pulmonary embolism. So now I want to shift gears and to talk about cardiogenic shock. Specifically, when you're assessing preload, afterload, contractility, obstruction, distributive shock, the last one is cardiogenic. I'm going to leave tamponade for the last thing we talk about, because I think tamponade is it could be its own lecture series. So I just want to briefly touch on right ventricle, left ventricle. Valvular abnormalities that are isolated usually don't occur unless you have, undiagnosed aortic stenosis, or, acute aortic insufficiency, or MR that's associated with hemodynamic instability. But these are exceedingly rare for this particular talk. And I want to focus on what's next. So first I want to say you have a mid-esophageal 4-chamber here. This is what this is supposed to look like. And I want you to take note of the size of the right ventricle compared to the left ventricle. And usually 1/3 to 2/3 is the appropriate ratio. So you can see that here on the left side of the screen corresponds to the right ventricle. This right ventricle is totally blown out. The patient's in right ventricular severe dysfunction with an underfilled left ventricle here. So that's your diagnosis. And then your treatment plan. The patient needs inotropic support. The RV is not a passive conduit. You have to pump blood through the lung in order to fill the left ventricle. So you either need to start inotropic support, RV afterload reduction, or mechanical circulatory support in order to figure out why this patient's RV is not functioning. Last one is obstructive shock. Once again, this could be its own talk. So I don't want to get too heavy into it, but for completeness sake, it must be discussed for the sake of rescue echo. And so what we have here is this is supposed to be a 4-chamber view. It's a little bit rotated with the tricuspid valve in the center. Coming down, we have a very thick right ventricle, and anteriorly we have an effusion. It looks like this is a completely thrombosed pericardial effusion here. So what do we see here? Once again, 4-chamber view, and you're like, well, wait a second, there's blood all here. That's correct. You have an anterior you have an anterior pericardial effusion that's at least, I would say, 2 centimeters. Now, there's diagnostic criteria for diagnosing tamponade that I'm not going to go into today, but they involve right atrial systolic collapse, right ventricular diastolic collapse, and a plethoric IVC, in addition to inflow changes that occur with blood flows, particularly in the tricuspid valve and the mitral valve. This is a case that occurred where a patient was undergoing a laser lead extraction that was high risk, and the lead got extracted and all of a sudden developed acute pericardial effusion that created tamponade physiology. The next case I want you to think about is a 28-year-old methamphetamine emergent washout. The patient's blood pressure is 50/30, and you are pushing ephedrine, epi, phenyl, you name it, and the pressure is not coming up. And this is the echo that you see. What's your diagnosis? Well, what you're supposed to see in the stomach is you're supposed to see a mid-pap level, and you can see that the patient's ventricle literally covers the entire sector width. You have profound, looks like dilated cardiomyopathy with a very poor systolic function, and you cannot even see the right ventricle in this view. It's completely dominated by the left ventricle. Another case of LV dysfunction is a 68-year-old obese patient with hyperlipidemia, hypertension, and untreated OSA that now has all of a sudden developed ST changes and this pattern here. So I gave the hint that this is LV dysfunction, but this is new regional wall motion abnormalities. You can see that this inferior wall is either dyskinetic or akinetic, and then this anterior wall is hypokinetic, and the septum isn't doing much, and the lateral wall isn't doing much. This patient needs to go to the cath lab. They either need to have probably a balloon pump placed, potentially mechanical circulatory support until they can get cathed. This is another image here where you start to see the benefit of having this view is you start to see which wall territories are involved. Now, you don't need to be certified in echocardiography to tell that this doesn't look normal. This whole apex and this anterior lateral wall is completely dysfunctional. So, what did we go over today? We went over SAM and the appropriate physiological flow that's supposed to occur, but because of SAM and left ventricular outflow tract obstruction, how to recognize it, who's at risk for it. We went over this. The second thing we went over is how to treat this. You have to get volume into the patient. You have to slow the patient's heart rate down. You have to decrease the speed of flow exiting the left ventricular outflow tract via either beta blockade or reducing or stopping your inotropes altogether. And then you have to create an afterload. So you have to create pressure that allows both increased in LV filling time, increased in LV filling pressure, and you need to decrease this velocity that's exiting the LVOT. We then talked about and revisited a very basic concept that helps to check off certain boxes of what is appropriate and what is inappropriately dysfunctional in the setting of undifferentiated shock in the operating room, specifically addressing stroke volume, which includes preload and contractility, both of the right and left ventricle, and how to differentiate between preload problems and SVR problems. We then talked about and revisited different components of scaffolding of different shock states, particularly with echocardiography. And then we talked about a basic algorithm to treat, retreat, and evaluate. If you have any questions, comments, or concerns, we can definitely talk about them now. If you don't have time to talk, you can write down my email. Please include any false information or information that is incorrect, as I don't want to pass along bad information, but I want to create an avenue to always improve. And anytime anyone wants to ever talk about Rescue Echo, I'm happy to talk with anyone about it. Thank you so much for your time.